So we are now on week 8. Next week is our exam, and then it's HESI review, and going on to our HESIs on a week 11. Um, Remember, week 12, I'm going to give you 2 times to show up on that week 12, Monday, Tuesday. I'm going to give you a 3 o'clock in the afternoon on that Monday. Tuesday is going to be 6 o'clock at night. Pick one of them, see me, that's your attendance. We have to make sure you get your attendance because if you miss week 12 and you miss week 1, that's 2 weeks, not attendance, you're dismissed from the program. So that's why showing up for week 12 is important. And I'll be bugging you if I don't see you, okay? Just to make sure we don't do that to you. So just plan in the future. Yes, there is a week 12. Week 11 is your HESI, so you don't have to worry about that. So week 8, lots of chapters, 29 through 32. We're going to go through them in a PowerPoint. Your last quiz, you're done with your quizzes now. One more exam in HESI, that is your KGA. There is a discussion question and there are NCLEX questions. Remember, those NCLEX questions are getting you ready for the exam, so treat them that way, okay? So here we go, and let's start our PowerPoint. So, GU, we're going to start out with actually child abuse because sometimes a child comes in to the doctor's office or urgent care or whatever, complaining of urinary tract infections, and it could be due to a child abuse case. All right. So, it's not always, sometimes it's just a normal urinary tract. Maybe it's there, masturbating. I mean, children do these things, but uh, some of the things that we look out for is with abuse. If they're having urinary frequency, it's telling you there's a urinary tract probably or yeast or some irritation there. Excessive masturbation, encoparesis, that's when you're constipated and a little bit of stool comes around it. Severe nightmares, bedwetting, that irritation, pain, genital area, or they just back off from everybody, physical, emotional. They just seem to be a little bit more distant. So, how do we assess urinary tract function? Well, simple, old urinary urinalysis, right? Urinalysis is going to have a quick dip, tell us something right away. Of course, you can culture it if we think there's a problem. Now, ultrasounds can tell us a lot of the structure, what's happening. IV pyelograms, we use those a lot for kidney stones, I find out, and especially older children. CAT scans, biopsies, cystoscopy, which is surgery, going and looking in the bladder, voiding cystourethropographies. Those are used in children to determine structural kinks and plugs in the tubes and why things are happening on one side or the other and all of the other stuff. Now, terms you need to know. Anything with dys is always difficulty. Dysuria, difficulty urinating. Frequency, your urgency, nocturia. And it's nocturia and uresis where they've always been continent and they've never had any bedwetting, and all of a sudden they start to get it, suspect a urinary tract infection. Something's happening there. And then, of course, we get to where you don't urinate, oliguria, or polyuria, where you're urinating a bit, and that's due to a lot of other things it could be. Now, abnormalities of the urinary tract. One of the things that little baby boys get is something called phimosis, and it's uncircumcised and it's tight on the tip. And one of the things we do teach parents is to pull that down once a day and clean underneath. Because if you don't, it will end up with a urinary tract infection. Because in between the skin and the penis is something called schmegma. It's this white cheese-like substance, like a petri dish, and it grows bacteria. So that needs to be pulled down, needs to be cleaned, every single day, okay? When you can't, it's a problem. My grandson, believe it or not, I could not, with my manipulation, whatever my tricks, I could not pull back his foreskin. So a determination was made he needed to be circumcised or he had increased possibilities of urinary tract infections. So that's the treatment that. Now, sometimes we pull it down and it gets stuck and we can't pull it back. It's actually an emergency. And we need to do something to shrink that, maybe a cold fluid of some sort, or something to constrict it, make it smaller, and we could pull it back up. Because if we leave that foreskin down, it squeezes it like a noose, and it could cause necrosis on the tip of the penis. So it is an emergency. Now, there's two things called epispadias, hypospadias, and this is in a male again, where the urethra does not come out the tip of the penis. Epispadias is somewhere on the top. The hole is anywhere there. Hypospadias is underneath. Now, sometimes it's almost at the tip. Sometimes it's way back. It's all different things. Sometimes it's with syndrome. Sometimes it's not. But usually we want to get these done before they're potty trained, before like the 18 months. The other thing we need to know about this surgery is these children cannot be circumcised. They literally take the penis and flay either the top or underneath, open it up, and create a canal, and then use the foreskin to close it back up. Major under general anesthesia surgery. They need the foreskin to make that extra space so that it can create a canal so the urine can come out the tip of the penis where it should. So it's, not a big deal. Urine still comes, but we need to put it where it needs to go, out the tip and not on the side. Now, exstrophy of bladder. This is an interesting thing where during fetal development, the abdominal wall doesn't close. And what happens is sometimes stomachs, intestines, that's an omphalocele, that's a different type, but similar, or the bladder is on top and it's not inside the body. So our big thing with this is to protect the skin of this baby. We want to make sure that it is protected from infection, and we want to keep the skin nice and not get all irritated so that we can push it back in and close the skin that's in good condition back up. The bladder still works, but it's on the upper side of the body, okay? I mean, even any other body part, it's on the top of the skin, not inside, but it's still all connected. So eventually they got to make room and they push it back in and they close it up. They try to do it pretty quick with this one. So this child is not going to be laying on its belly at birth at all. You're not going to wrap them up because you need to monitor that area, right? And then, as I said, no tight diapers. Keep it moist, keep it underneath, clean, dry, protect the skin, and we'll be to surgery soon. Must be hard for a mother to see a child with their bladder outside, right? Now, I said obstructive uropathy. Many times we don't figure this out until they are toddlers trying to go through potty training, or we're seeing frequent urinary tract infections. Something is not going on there. And then we go and we look and we find that it's something obstructive. Now, it could be a ureter, it could be one of the valves, it could be the kidneys, hydronephrosis, all of these sort of things. Now, toddlers, we want to make sure that whatever we can fix it before potty training. We don't want to bring them attention to that's different than somebody else's. We want, and that goes into preschool and school age again. Oh my God, something's wrong with my whatever, and I have to have surgery, and it's embarrassing to talk about. And again, distorted body images. And then, of course, adolescents worrying about is their sex parts going to work if it has to do with those things. Now, urinary tract infection, really common in little girls and young boys that are not circumcised because they're not getting cleaned. But we can say overall, girls are the most. It's because your urethra is short, it's wide open, it's close to the anus. So you're potty training, wiping back to front, you're sitting in bubble baths, or you're in these nice, cute little outfits with tights, which hold heat in. It's not cotton and it creates moisture and causes infection. So it is E. coli directly from the stool. So these little girls, what are we going to do? Well, younger infants, depending on them, are usually hospitalized. They don't have an immune system, do they? So they need IV and IV antibiotics. Older kids, they've been through a lot more. Their bodies are stronger, oral medications, and us telling them, make sure you finish all the doses, right? Also, teaching parents how for them to wipe themselves, how to go to the bathroom better, and to increase fluids. I think increasing fluids is one of the big things on those children. Little girls shouldn't be in bubble baths and they should wear white cotton underwear, not even colors. And all those princess underwears and stuff. Oh my goodness. I have a little girl that's exactly what I'd buy for them. And I know it's white cotton is the best for decreased urinary tract, but we all do it. Also, those cute little tights and those little ruffled bottoms. They shouldn't. It should be more loose fitting clothes, white cotton underwear, boring, but we are protecting that child's urinary health. And then, of course, as I've said a couple times, increasing oral intake. Now, nephrotic syndrome has nothing to do with renal failure. I want to say this again. Nephrotic syndrome is not renal failure. Your kidneys are working. But you know what they're saying? Protein, yuck, bleh, I hate you. And it spits out all the protein in your urine. The protein from your blood, which is albumin, everything gone. It comes out. So when you lose that um, molecules out of your blood, it becomes to that point where it starts putting fluids interstitially and you start getting swollen everywhere. Okay, because lack of protein in the blood, because the kidneys say, I don't like it, keeps getting rid of it. It is boys more, ages 2 to 7. There is an immune component. That's that T cell dysfunction. That means these children are immunosuppressed. So we have to be careful for infection, okay? These children, when they're in this, where they're really retaining and really swollen and losing lots of protein, we will put them on steroids, and the steroids do help. Now, with nephrotic syndrome, you've got that big weight gain. So you're going to be watching that scale, right? Daily scales, daily weights, intake output. Very important on this one. We're going to look at that swelling. What do they look like? It's usually generalized everywhere, even their tongue and their cheeks, and they bite their cheeks and then they don't want to eat because it hurts. Okay. Blood pressures are usually normal. We're talking kidney here. This is the different one. Glomerulonephritis, you have elevated blood pressures, but nephrotic syndrome, your blood pressures are normal here. So it wouldn't be let me check the blood pressure. Has to be a kidney thing. We know you check that urine, it's going to be 5, 8 plus your albumin protein, 4 plus is highest, but it's a lot that's going to be there. And then, of course, these children, they're immunosuppressed. They're going to be losing their white cells, the ability to fight infections, and go to neutropenia. Okay? Neutropenia means they can't fight against nothing. So we give them steroids. It reduces the protein, it reduces the edema. And remember, not enough protein in the blood means when we give medication, it's going to be more free flowing drug. So means you need littler doses of some medicine, okay? And this is a concept that's really difficult to understand, but medication goes into the blood system and hops on an albumin or a protein. The rest is left in the blood. That's free drug. That's what makes your drug level. You don't have any albumin protein to hop on, that level in that blood's going to be toxic. Okay? That's what I'm talking about. These children, diuretics don't work on them. It's the steroids that take care of this here. Okay? So we're going to monitor fluids, restricted, and no salt. Anything that will decrease the amount of swelling. So this again, child, is immunosuppressed. No immunizations during this time, okay? Because this kid will get the disease if you give him whatever. So these children, they're worried about intake and outputs, the kidneys, protein, urinating it out, retaining fluid. Nursing care always with fluid, intake, output, daily weights. Yes, Jessica.
Is that just live vaccines or any vaccines?
Any vaccines must be cleared through the physician. Live vaccines, absolutely not. Any immunosuppressed child or adult, and immunosuppressed could mean on steroids because you're immunosuppressed on steroids. So these children, everything needs to be looked at very closely. It might be, yes, you can get that flu vaccine if you get a certain type. There are different things that we can do to get, like, remember, I'm immunosuppressed, so I've got to watch what I take, types of vaccine also. Okay. So the nephrotic syndrome, we're going to be doing intake, output, daily weights. Okay. And then they're going to do little dips of their own protein. Those little dipsticks that we have in the hospital, they're going to be dipping for protein themselves. And they're going to be watching, the steroids. What are they on? Are they tapering off, et cetera, et cetera? And again, with edema, getting up, moving, walking sort of moves that fluid around and helps get rid of it. Okay. And then, of course, us as nurses and them washing hands, as simple as that. So I said, another renal thing is acute glomerulonephritis. Acute glomerulonephritis is just like rheumatic fever, is caused by a group B strep infection that wasn't treated. Strep throat again. So strep throat not treated or undertreated causes rheumatic fever, which is your heart valve damage. It also causes acute glomerulonephritis, which means it stops your kidneys from urinating. So now you're retaining fluids. Okay? How do you treat strep? How do you treat rheumatic fever? Again, penicillin again, okay? Wilms tumor is a nephroblastoma or a kidney tumor. It's usually actually boys. That 3 to 5 year old is the big thing. And you just see a big abdominal mass in the abdomen and it's not painful. The thing with that mass is it's fragile. So we don't need to be touching that to assess it because it breaks off and metastasizes really, really easily. Okay. So as we're changing the diaper, turning them over, we're not touching that abdomen, all right? Got to be very careful. Now, it does affect the kidney. This one can worry about the blood pressure, but they do surgery. Sometimes chemo, sometimes radiation, sometimes both. And then they go in and they remove that tumor. And these children actually do very well, usually with it. Now, hydrocele is basically fluid around the testicle, and it's painful. Now, sometimes if it continues there as a young infant, continues and the fluid stays there, it can go in and figure out where the fluids come from and get it removed. Cryptorchidism. This is when the testicles or fail to descend into the scrotum. All right. And this is they're up in the air. Now, the big thing with this one is when we want to look at those testicles, if we have a warm room, we can see them hanging better because the scrotal sac distends. So hopefully those testicles will come in there. So making sure that they're there is what we want. So we prevent somebody from being sterile in the long run. We can do surgery. Sometimes we just watch it. Sometimes we do hormones. And if a child is older, an older child with it, we're going to put that support on them. Okay. Remember, kids that are older getting surgery on their private parts are concerned whether they did something wrong to cause this, right? That's a big common thing, preschool and young school age children. Other school age children up into getting older are worried, is it going to work when they're done doing these things? So please reinsure these poor children. So somewhere between 3 to 6 years old, this is your preschool. Like I've said before, is they start getting curious about body parts. Mine is different than yours. And this started in the potty training, right? So, and this is just telling you again, tell them it's not their fault and get them prepared and that it's not going to hurt them in the long run. So, a skin condition, anything on the outside of the body, right? We know that it's a big system of the body. We know skin disorders can be a systemic, could be just an allergic response. You know, we know that nutrition affects it. It can cause skin conditions, and there's what medical treatment do you do? They're also confusing. I think dermatology is probably one of the most frustrating of all the things that I've worked with. So when you're looking at these sort of things, how big is it? What's the color of it? What does it look like? Does it itch? Does it burn? Does it nothing? Is it in bits and pieces? Is it spread? Is it, localized? What does the skin look like? These are all things that we would be describing these lesions. Now, if a kid is scratching, the nails need to be kept short, number one. But why are they scratching? Do they need lotion? Do they need anti itch something? Because that scratching is going to cause infections, and we want to decrease those infections. And the more they scratch, the deeper they go into the dermis, right? And we don't want that to happen. A sty or a hodolome. My grandson just had a big one over his left eye. Almost 2 months it was there, never came to a head. But mom didn't like this big lump in her cute little boy's eye, right? But they're there, they're sebaceous glands. And so they don't always come to a head, little warm pack, and they're gone. Strawberry hemangiomas. It's dilated capillaries and they're very vascular, okay? Many of them go away by themselves. Some of them, they go and they'll take different medications for. I've seen giving them Inderal. I've seen them hormone creams. I've seen many different things. So that would be if it's there, it still continues, it doesn't darken. As the child gets older, then they would order, a different port wine Navis. This again is this purplish area. It looks like splashed wine in the face. That's what it's port wine, what they're talking about. Um, it's different because this lesion can get doesn't disappear. This is something that's gonna stay there. And that it does usually get darker as they get older. So with a young girl, that might be some body image area, right? Cafe au lait. This is when you have those dark and light patches, or that hypopigmented macules, So you have all different, shades of skin with these. Butterfly rash. This is lupus, right? Their little cheeks get all rashed up, and they're all different looking types of rashes. There's not really one that you could say that you could see. Scaling skin eruption, round the mouth, horseshoe shaped on the chin, the cheeks, could be perianal, papules, and scales. This is a zinc deficiency. As I said, there's so many. Which one is that viral infection? Which is something you treat? Which is due to nutritional? They're really difficult to keep up with. And I've tried through the years. A vascular birthmark, it resembles a bruise, but it does change its pattern and the way it looks as it gets older. Hemangiomas, of course, if it's around the chin, you always worry about the pinching airways. And that would always, anything around an airway, you always be worried about those things. And then around the lower spine can cause some lower leg, paralysis and paresthesia. Milia, prickly heat. This is those little babies that get really hot, and you see these little tiny little rash there, and it's itchy, it's in skin folds. What do? Just give them a bath with a mild soap and just let them dry and frequent diaper change and have them nude for a while. And that to the air is all we need to do to cure those things. Chafing can happen. It could be the diaper, them walking, them roughing. Of course, if they are wet with urine or stool, or if they vomited and we didn't clean underneath the neck, all of these things are prevented by keeping them clean and dry. Cradle cap. I think this is one of those things that, as a mother, you want to have this most beautiful hair with a little girl, with a little bow, and they've got this cradle cap, and you're like, "Ooh, but we got to get rid of that." All we need to do is shampoo it, keep it well oiled, and a fine tooth comb, easy, tenderly. You brush it, and it will come out, and it will go away, but not overnight. It's going to take multiple times for that.
The best thing I found for that, if anybody is dealing with that, was breast milk and then coconut oil.
There you go. Yes, absolutely. Totally agree with you. Coconut oil is amazing just for lubrication on babies generally. Yeah, my daughter used it. She did a lot of research on it. Yeah, thank you for sure.
And a toothbrush is what I used to get it in because it kind of got down in.
All right. You can use a soft one. Absolutely. Sounds good. Diaper dermatitis. Oh, this is a mother's nightmare. When the baby gets that diaper rash, this child's not going to sleep at night. As soon as they urinate or stool, the kid's going to be screaming. It's horrible. How do we prevent these things? Well, is it an allergic reaction to new soap, new diapers, new clothes, new powder, whatever? Something has caused it. Could be a new food you've introduced. I found my kids hated Huggies. They could not wear them. They could wear Pampers way back when. So as soon as you put one of those on, oh, that's the end of it. Again, trying to keep them clean and dry. And if they end up with yeast, we're going to put the nystatin powder down there or the nystatin cream, whatever the doctor orders. And then we're going to do those areas of tummy time, no diaper on. Let that butt be up in the air. Acne vulgaris. This is what happens with older children and hormones coming on. It is increased of fatty substance called sebum. It's a plug. There's open blackheads. Closed are those white heads, and that's the inflammation of them. The thing with acne is just routine cleaning, don't over clean. Greasy hair products, cosmetics, no, because it puts more grease on the face. Now, there's all sorts of topical creams, oral treatments, etc. Follow the instructions as it's prescribed. Some adolescents wants to overdo something, and no, it should be as prescribed because overdoing it with something could make it worse. Herpes simplex, cold sore. Yes, they can look like that poor little baby. I've seen it like that. They hurt, they're uncomfortable, they're oozy, and they're juicy. How do we treat this? Well, trying to keep it from cracking, because like those lips, the cracking, sucking on a bottle can be uncomfortable. You protecting yourself with gloves, keeping that child as clean as you can with like milk after they eat, and it's antivirals, oral and topical, that we keep it on there. That eczema we talked about is, again, it's a lot of keeping that skin nice of moist, okay? We know that actually breast milk children have less eczema than do bottle fed. It's just part of it. And they say, yes, it's going to be a sensitivity to a substance. There's an allergen that's causing some reaction in the body. And in the, upper states where you have this winters, sometimes that dry air can cause eczema in some children. It can be bacteria or viral. And the thing with children, that if they have eczema and you're around other adults that have other sores of some whatever, you shouldn't let them touch each other, because that open sores can put that whatever it is into that baby, okay? So a lot of times, um, when we have eczema and the body is having an immunization, the body's making their own antigens now to that immunization. Sometimes this flares. And that's just something that we do expect. So with eczema, the big thing is itchy, itchy, itchy. So hydrate the skin, relieve that itching, emollient baths, whatever the combination of. Sometimes it's just that Aveeno oatmeal bath. Sometimes you make your own cornstarch, baking soda, bath oils. I've seen olive oil, corn oil, vegetable oil. I've had parents use every emollient thing that they could think of. I think coconut oil is the best. Plus, it smells really good. Your baby smells like a fruit farm, and you just want to kiss them all over. And it works really good, and it doesn't stain clothes. So it's a great oil to use. Again, with eczema, if it gets really bad, we are going to be giving those hydration things. We are going to be giving those lotions, corticosteroids, and antibiotics. If it's infected, we got to fight it. It will go systemic. So basically, when we are using creams and lotions with children, remember it's better after a warm bath. The skin pores are open. You stroke at the area of the hair growth, and more doesn't make it better. More can make your child have an allergic reaction. So less is best. Put it on as well as you can. And infants, they do have those little elbow things. So if it's here, they can't get to it and they can't itch it. And it's better them not to itch it, keep it away and let it heal, okay?
Sure,
And
sure.
they do use steroids. But again, this is when there's no infection, because any infection, steroids is going to mask it some more, and we don't want to do that. Staph infections, we hear this is, you get cuts and you get an oozy, juicy sore. We know that they're staph. We put antibiotic ointments on them. They get big and bad and go deep. Of course, IV antibiotics. In the hospital, the biggest staph infection we worry about is MRSA. MRSA is a hospital acquired infection, and these children are resistant against Staph aureus. They're put in isolation rooms. Nurses, you're going to wear gloves, you're going to wear gowns to go in that room. Scalded skin syndrome. This is when it looks like you dunked your baby in hot water and the skin is peeling off. Literally, that's what it is. And Pentago, this is that bullious, juicy, infected type of infection treatment. you're going to put on um, topical antibiotics and oral. If it's really, really bad, you can go to IV antibiotics. Fungal things, ringworm is a fungus. So we can have the capitis, we can have the corpus, the pedis, we can have the jock itch, the crucis, anywhere where these round things come up. These are all fungal infections, and we treat it with a fungal cream. And we give lice can be anywhere there's hair. Okay. And again, there's creams and permethrin that we use to get rid of these things. Scabies, this is what we talked about at the when you go to hotels, right? You're worried about scabies. Was a big scare out there that the mattresses had them in the mat. That we had to look at the eggs and whatnot in the mattresses and do these lights on it. I was watching this one documentary. This crazy guy was going around checking hotels, but the thing with it is that it gets in there and it itches like crazy. Yes, Angela.
Professor, I was gonna say my son had that. Not scabies, but the eczema, like when he was little, and I noticed he don't have it now. But that's what I did. I gave him the bath with the Aveeno
Hmm.
oatmeal. And another thing, his pediatrician told me, he said when I wash my children clothes, not only to make sure was I using Dreft soap, but also don't use fabric softener. Don't use like, Tide and Gain with their clothes because it has a different effect on their skin than it does adult skin. And she told me don't use fabric softener because the ingredients in fabric softener makes the eczema act up. So when I took her advice and I stopped using fabric softener on his clothes, I noticed the eczema went away
Yeah,
completely.
absolutely.
Yeah.
You couldn't have said it any more perfect. There's all those, even Tide Clears today are okay, but I like Dref. I like the smell of it. I think Dref is the most amazing smelling laundry detergent for babies. I used to
Yeah,
enjoy.
it is.
Uh,
That's what I use. Yeah.
yeah, I do like it. But thank you so much for that. Remember burn injuries? How do we prevent burn injuries? Making sure there's cords are put away, pots and pans aren't the handles hanging out, and sometimes burns are abuse, neglect, and many times they're not. So nurses, we got to figure out, was it that or was it an abuse? Okay. There's thermal, there's chemical, electrical, and there's radiation. Again, there's still burns. There's still the rule of nines, right? The thing with burns, always be concerned. You could have a chest injury, but maybe some flames went up. Always, number one priority in burns is airway, airway. Because without an airway, nothing else matters. It could be on the chest, the shoulder, arm, the back. It could have gone in the mouth. Always check to make sure that number one. All right. I don't go over complete into burns, burns, burns. Sunburns. I live in South Florida, and so many of you do too. We know it's putting on a sunblock, not going out to high areas, and to prevent sunburn today. We know it's not good for us and it can create skin cancer. Now, up north, I used to go snowmobiling in 18 below zero weather. So I've been involved with the possibilities of frostbite. Now, making sure that we keep the fingers, the toes warm, and then you can lose toes and fingers because that cold has shrunk those vessels so much, there's no blood supply, and then the tissue dies. Communicable diseases. So, communicable diseases, these are some terms now, transmitted from one person to another. Incubation, this is like chicken pox, right? Time between exposure to the pathogen and onset of clinical symptoms. That could be 4 to 7 days in chicken pox. You were exposed. Prodromal, time between earliest symptom and the appearance of that rash or fever. You could get that maybe don't feel good, and then that's that prodromal until you show the outburst of that rash. And a vector is an insect or animal that carries and spreads a disease. Talk about a tick. Ticks will carry a lot of them. Pandemic, we just had one. Worldwide communicable disease, COVID. An epidemic, the localized increase. Endemic is just something that continues to happen in a certain place. Opportunistic infection is when you have a person who can't fight disease. And, like, for instance, HIV, PCP pneumonia is an opportunistic infection. That's what that means. And healthcare is associated infection. That's your MRSA, that's your VRE. These are things that are hospital acquired infections. We know that it all depends on, the child, and we know it's on the age. We know that sex, genetics, nutrition is huge when we think about infections, and their immune system. They have no nutrition, immune systems down, they're going to be getting whatever that infection is, and is their skin intact or is it open, infection? Now, types of immunity. Now, sometimes you're born with immunities. Usually came from mom. You're born with them. Now, acquired, you're not born with it, but as a result of having the disease or receiving vaccines or an immune serum, now you have an acquired immunity. That could be your Hep B vaccine. You didn't have the disease, but here you go. You are taking care of measles and mumps. You might have had mumps. I did. So I've already built up that immunity because I had it. Or I took my influenza vaccine, right? That helped me. Active immunity, you make your own. For some reason, you make your own immunity. Your body fights against it. And passive immunity is something that you give the antibody to that person and it doesn't last forever. It's just a short period of time. Aseptic technique prevents the spread of infection. Standard precautions, hand hygiene, using proper PEE is what we need to do. If it has to do with from head to toe here, and I know sometimes it's hard. Oh, I got to put all that on to go in that room. Yeah, you do. I was, believe it or not, when they came out with one of the influenzas, swine flu. I had swine flu and I was in the hospital and I was under respiratory isolation, as in you wear gear to come in. I would have 3 or 4 lunch trays sitting up in my room, just lined up because nobody wanted to come in. I'm lucky they just dumped in my tray during it. So remember when I tell you that people in isolation get ignored. Thank goodness I was a healthy one that was there. Airborne. Airborne, that's your meningitis, bacterial meningitis, airborne. You're going to need to put on an N95 mask when you're with that child, and you're going to have that child in a negative pressure room. Contact precautions, again, is it skin to skin? Remember that's private room, gowns, gloves, and of course, hand hygiene before and after. Droplets, again, this is a regular mask and a gown and gloves. If you're going in with this child, like for instance, RSV, and again, hand hygienes whenever and all the time, right? I think that we've learned it. We've learned through experience, no artificial nails, tips, reps, gels, nail jewelry, because they say the infection gets inside and it hides in there. And now you're just carrying it along to your patient of whatever sort. Because I know that when artificial nails became vogue, of course I had them. And then they realized they took a bunch of cultures and they found out that they were carrying a lot of disease. Again, teaching families, teaching those children hand hygienes, immunizations, the importance, food storage, the pasteurized milk, how to defrost, how to cook meat, going into community bathrooms and they have towels, we don't touch them. I'd rather I just wipe my hands off in the air, right? Insects, ticks, that's the big thing. And no sandboxes, believe it or not. That harbors eggs of all sorts of things, pinworms you can ingest, and oh yeah, pinworms. So yeah, we don't do it anymore. Rashes, erythemas, macules, papules, vesicles, pustules, scabs, and pathognomonic. These are all different sort of descriptions of rashes. We know that healthy people, one of the biggest things that they are been focusing on for their 2030 routine in children is all about being immunized and immunized against any disease that can be um, transferred from one to another. We know vaccines are given. We know that if we are that person giving them, making sure that they're stored properly, that we treat them in the right manner. We know you can get allergies to these immunization shots, believe it or not. I luckily have never seen an anaphylactic shock to any immunization I ever gave. But knowing that epinephrine is there, if you're going into shock, anaphylaxis, epi is the first thing that we're going to be given. And they should be monitored for about 20 minutes. There is Baker's yeast in hepatitis B. One of the reasons why I can't take it, because I have this intolerance towards it. Eggs, no influenza, or MMR. Neomycin, they shouldn't have the IPR or the MMR or varicella. So these are little things that, okay, you do have these allergies, you can't use those, but that's the only excuses, right? When we can't get immunizations, here we go. Immunocompromised, pregnant, if you're sick, if you're on steroids or have a fever, makes sense. Bioterrorism, it's more than ever today. You always worry about these things. We think about what happened in the Twin Towers. My son actually went into the army 3 months later after Twin Towers. He said, well, if they're going to call, going to be at a war, well, I'm going to go now, get training. And he's been in since. That's when my son went in. So again, just being safe when you don't know what things are, don't touch them. You don't have to be curious. Get somebody, if you receive something that don't look right, get it out, give it to somebody. In South Florida, we always know to be prepared. We have water in the house. We have, our cans, batteries, et cetera, et cetera. But this should be in any home, having that first aid kit and medicines, if we know in advance to get them. But sometimes it's just a tornado that comes and you don't know. All right, sexually transmitted diseases. We know that this is spread through sexual activity. You can go from mom to the baby. And again, sexual abuse. It could be an older person, maybe in drugs, contaminated needles. Nurses need to report these to the public health department. We can track, is there an increase in syphilis? Is there increase in gonorrhea? Is there more public education that needs to be done? That's why we report. Not to say, oh, this person's been a bad person, okay? Things happen. So in nursing, you're dealing with these sort of things, the sexual transmitted disease. Don't make that person feel bad. Things happen. Especially in our ages, it'd be our adolescents mostly talking about this. Give them their privacy, let them ask questions, give them that confidentiality that they do need, okay? And let them understand on their level of understanding, all right? HIV in children, a lot of times we know this at birth because mom was. So we'll treat them with antivirals. And do you know many HIV mothers having babies today can have negative HIV babies if they've been treating them all along with these antiretrovirals, okay? So a
Professor,
lot of different
they
stuff
don't
there.
they don't get HIV if they come through the birth canal. I thought it was if you don't want the baby to have HIV, you get a C-section. That's not true.
I
You
think that's
know,
herpes.
there's been
If you
both
have an
trains
active,
of thought.
if you have an
Hold on,
active
hold on, hold
herpes
on, hold on,
outbreak,
hold on. Professor, what you say?
It could be both ways. It's the train of thought. Go ahead, Jessica. You were trying to say something.
yeah, I think that's with herpes. If you have an active outbreak, they won't let you deliver vaginally, but you can have a C-section and the kid won't get it.
Well, Angela, let's think about it. HIV is blood. Whether you come
Mhm,
through the birth canal and you have an episiotomy, or you've cut open the abdomen and take it out, it's still exposure to blood.
mhm.
Now, what they say today, HIV positive mothers at age 22 weeks can start taking antiretrovirals for the baby. And
Okay,
immediately at birth, the baby is put on antiretrovirals to boost their immune system.
right.
Many of them by 1 year old are negative HIV.
Okay,
Now, there was a case where there was triplets, girls. One had AIDS, one had HIV, and one was negative. Who knows? So, yes, and that's a real case that I did see. So, yes, it's this big thing, HIV. And Jessica, you are right. It is the herpes outbreak that they don't want them coming through there at all. Absolutely right.
okay.
That's why
I
they
was
put them
asking.
on antivirals before delivery. They
Yeah,
start
I
making
was
them take
asking
it
because
at 36 weeks just
I
to
was
be
asking
safe.
because I know actually three OBGYNs that I follow, and they've been doctors for years. And I know that's what they do. They put the mother on the antiretrovirals. However, they always advise their patients to do they tell them not to breastfeed, and they always advise them to do a C-section, and they say it's safer that way. That's why I was just double checking what you asking, but thank you.
No, no, no. Thank you very much for your comments. I don't mind them at all.
If
You know
if
that.
HIV is from blood, they can't breastfeed at all.
Because your nipples can break and have little blood in it.
That
Yes, it's a
that makes
big
sense.
controversial thing. It's like, well, think even if you take medication or drugs, it can come out in the breast milk. So they say no, that's you can't. Yeah.
Professor, before you move on, I would like to ask a question. Okay, so it doesn't matter if somebody, I'm asking to make sure, if you have HIV, you can it doesn't you can't just have it you don't have to have a C-section because it have to do with blood. So it doesn't matter where it come if it's HIV.
It's a physician's choice.
Okay.
I don't want what today's practice is, because every 6 months or so, there's new research. What's the best way? I mean, if you knew back in early 80s, when HIV was just named, it's just like all of a sudden COVID. We have HIV. We get a patient in the hospital with HIV. That we would have to dress up with caps and gowns and masks and gloves and booties and because of HIV. Okay. That's a change in practice, what I'm talking about. So many changes. I don't know all of them because we just wash our hands now. Okay. Big, big difference. Big difference. All right. Great. Great questions. Thank you. All right. Who wants to win a Kahoot today? Kahoot. Hoot. Come on, Lucinda. Say I want to win.
Peanut butter.
Peanut butter. There we go. I love it. You're making me hungry for a peanut butter and grape jelly sandwich on rye bread and a glass of milk. No, actually, I think I'm having some curry goat for dinner tonight. Seriously, I have some. So remember, this week is all the reviews. All those reviews are there. We have that dosage calc thing there. Make sure you go over and know how to do those questions. Look at the Cahoots. You're always going to see those concepts somewhere on an exam. And of course, that study guide, as you hear my review, what could be select alls? I'm like, this could be, or this could be, or this could be, or this. There's so much you can figure out these things, okay? All right, let's get going. Thank you, guys. Chapters 29 through 32, a whole bunch of stuff. Start with a multi. The nurse caring for a child with nephrotic syndrome is to alert to which classic symptoms of this disorder. Remember, nephrotic syndrome has nothing to do with renal failure. What does the kidney say? And then what happens? It says, yuck, protein, I don't like you. And then you swell up because of the difference of that isotonic, hypotonic solution thing, and fluid just goes interstitial, and now you're just swollen everywhere. And then you're exhausted from all of this extra going on there. Very good, guys. A multi. Genitourinary surgery is especially stressful for preschooler. What factors lend to this stress? So remember, think about your preschooler children, right? You talk about that age and the way they feel about things. Number one, they feel anything they've done wrong is why they've got something wrong on them. I did something wrong, that's why I'm being punished, and this happened. But remember, these preschool children, they're a fear of castration. Everything's a punishment because they did something wrong here. And remember, it's mom and dad, and curiosity and masturbation starts. So it's that curiosity. It's not about fearing death, it's all of the other stuff.
Professor, I thought you told us they fear death. Like they ask you sometimes, am I gonna die?
Older kids. What special considerations are related to long-term prednisone therapy in preschoolers? They think they're going to die is usually the older kids, not necessarily preschoolers. Preschoolers are more about mutilation and castration. That's preschoolers. But that was a great question also, Guy. Very nice. All right, prednisone therapy. What does it do? Well, in older people, it can cause your blood sugars to go up too, right? It also can cause you to be immunosuppressed. So, immunosuppressed, I'm at increased risk for infection. And because of that prednisone, I can't take some of the immunizations. So, very good. It has nothing to do with alteration in nutrition. In fact, prednisone makes you hungry. All right? Has nothing to do with sex organs. To prevent urinary tract infection, which is the best beverage for the nurse to recommend to keep the urine acidic. And you'll be surprised. It's apple juice, believe it or not. Now, orange juice, apple juice, they're good. Some children don't like orange juice, so apple juice is that great alternative because they like either one or the other. When weighing the diaper and subtracting the weight of the dry diaper, the nurse records 30 grams and blank mLs. Now, all right, so 30-gram the diaper weighed, and now it weighs 60 milliliters. If you subtract that dry from that wet, it comes out with 30 grams or 30 milliliters. So it's either whatever it is on the gram. So as I said, size 1 diapers are 30 grams. You take it off the child and that child weighs 60 grams at that point. You just subtract it. 30 grams is 30 milliliters. It's 1 to 1. I'm multi. Strategies to prevent a reoccurrence of urinary tract infections in a child. I've mentioned a few. So the one thing we don't want is bubble baths. Good job. Wipe from front to back, lots of fluids, make sure they urinate frequently, and cotton underwear. Yes, white is the best of we could do, but at least the cotton, I'd be happy with that, right? When do you correct a hypospadias of a newborn? Remember, that's when the end of the penis is not where your urethra comes. Hypo is underneath, anywhere underneath the penis. It's not out the end. And remember, you got to keep the foreskin. That can't be circumcised. So we want to do it before they're really getting into total potty training, right? So before 18 months, especially before preschooler, where we think we're going to castrate them if they touch their penis and fillet the whole thing, right? I can't even imagine that poor child. You think that they have been mutilated for life because that's what it looks like. Foreskin is retracted and very tight on the shaft of the penis. You're unable to return it over the head of the penis. What are you going to do? So that's a paraphimosis. You pulled it down, you cleaned it out, and oops, it can't come back. So you're going to tell that charge nurse immediately because you actually have to get the physician. Maybe he'll say to put cool on it, which constricts, decreases swelling. It might come up, but you might have to have that physician come and pull it up. Take even hemostats and pull it up because it is choking the tip of the penis. That penis can die. So we got to be careful. Tell that charge nurse, call the doctor. Which urinary diversion procedure is the least damaging to the body image of the adolescent? Urinary diversion. Now, I didn't go any of these things. Sometimes children are born and their bladder doesn't work the way it should. So they have to put their urine into some area else. So we can either put it up to the abdomen, urostomy, nephrostomy, or suprapubic, which means there's a hole in the abdomen. So now if they want to become intimate, the partner's going to see their bag and urine. An ilia conduit connects the ureter to the bowel. So it's coming out the rectum instead. And there's ways that they've learned how to control it so it doesn't leak. Okay? Ilia conduit is a very different procedure, but it's really for that adolescent and body image thing. Which physical assessment will the nurse omit when caring for a 2-year-old child diagnosed with a Wilms tumor? Remember, Wilms tumor is a kidney tumor. Remember that tumor is very fragile and little metastasis can be spewed in the abdominal cavity. So we do not touch that abdomen. As in, we're not assessing those bowel sounds on this child because we can't touch the abdomen like that, okay? It will break off and cause metastasis.
You can't even touch it lightly with a stethoscope.
But not hard. What is the probable cause of acute glomerulonephritis? What they say is just to leave that abdomen alone. Yes, you can put on diapers very lightly, this and that, but we can't do any palpation at all. Maybe listen with stethoscope as long as you're not pushing deep. Okay. Remember, acute glomerulonephritis is like rheumatic fever. It's caused because of a strep infection that wasn't treated properly, sore throat. So, what is the treatment then? Just like rheumatic fever, penicillin, and 10 years prophylaxis. Okay, same thing. A multi. What will the nurse caring for a newborn with extrophy of the bladder include in the care? Remember, that's when extrophy, the bladder is born on the outside of the body and it didn't go inside. What is our biggest thing that we need to worry about? Because eventually we need to get that bladder back inside the abdomen. They sort of make room little by little, day by day. Well, they need to be on their back. They need to protect the skin and keep it nice and healthy. And we're not going to cover this bladder with a shield. It might be with a sterile, moist dressing to keep it nice and moist. So when it goes back in, it's still of good quality, and then protect the skin underneath. A child's brought to the emergency department with burns on the face and chest. What's the nurse's first priority? Burns. What did I tell you to check first? I mean, you don't know if this kid had a stick that was on fire around his face first and threw it down, and now he's burnt on his feet. You don't know. So again, always, always respiratory first. Very good. A multi. What should the nurse stress or teach to the mother of a child with impetigo? I'll still never forget Christian. The back of his knee had this mosquito bite. It was itched too much, as mommy said. And it kept getting bigger and bigger. And I'm like, yeah, this is impetigo. And it got bigger and bigger. And I'm thank goodness I knew what it was, because I'm immunosuppressed. So to protect me. These lesions are staph or strep. They're highly contagious and they need to be treated. They needed to be cleaned and they needed an antibiotic ointment on it. The lesions are bulbous. They're like juicy. They're almost like golden in color. Okay. And they're painful where my grandson had it. And it took a good week of me treating it to get to the point where it was almost gone with oral antibiotics. Multi. Which factors activate the herpes simplex virus? I mean, this is your little coleslaw. Anything. Fever, stress, sun, menses. I knew going out in the sun, burning your lip, you could get a herpes. Fever, always you're going to see that come up. Anytime your immune system is down like that, and menses, that hormonal, all of them cause it. You know, that possibility of them to come up. Football players are taking oral griselfulin for tinea pedis. What should the school nurse caution them to avoid? Tinea pedis. What is that? That's athlete's foot. This is an antifungal medication. The biggest thing about antifungal medication, if you took it with a drink, you were going to be like you had taken antabuse, which means alcohol goes in and you're going to be vomiting and you're not going to be able to control it. You'll vomit, you'll vomit, you'll vomit, you'll vomit. It's a real caution that should be placed on antifungals. Maybe you go out and, you know, an adult has a glass of wine with dinner. Oh my goodness, they're going to be suffering for a long time, vomiting, vomiting, vomiting. What is the correct nursing response to a mother who asks, how can I get rid of the baby's cradle cap? Coconut oil, right? So what the book says is rub oil on the head at night and bathe them in the morning. I mean, is there a right or wrong way? It is keeping it moisturized, keeping it clean, and then using a fine tooth comb to get out, all of that crud in the head. And it does. It takes a while, but it does come. I like the idea of that soft toothbrush. I think that's a great idea. Child has experienced intense itching eczema between the fingers. It's worse at night. What is this? It's all at that little hot spots, right? Underneath the arms, it's warm. Between the fingers, it's warm. What is that? It's actually scabies. It's one of the ways that you determine what is it? Is it scabies? Is it, ticks? What is it? Something else? But that is definitely scabies definition. Worse at night. An adolescent presents with a butterfly rash. What diagnosis does the nurse suspect? Sometimes it's all they come in with. Sometimes they'll come in with nausea, vomiting, seizures. But usually it's just this little speckle of stuff on their chin, on their cheeks, and it's lupus. Sometimes it's so hard to figure these things out. Another multi. Which food sources are high in soluble fiber? Raw fruits, not your cooked vegetables, okay? Beans, yes, it is bran cereal too. That should have been keyed in. But beans, black beans, great choices to use, okay? But don't cook those vegetables, don't cook those fruits. Always
They
raw
take
is
the fiber
better.
out. Yeah, I remember you
Yeah,
said
it
that in the
does.
lecture last time.
Yep, raw is better. Glycosated hemoglobin test, hemoglobin A1C, can evaluate average glucose levels over a period of blank to blank months. Remember, this is one of those first tests that we do on a child that we might suspect that has diabetes. Now, adults, they say 6.5 is the number they call diabetes. Do you know children are 7? They give them a little bit more, okay? And it's about 3 to 4 months. We can see where those blood glucose levels have been. And in children, we want it less than 7. Usually it's, less than 6 for sure. What occurs as a result of an inadequate secretion of insulin? So your pancreas is not secreting enough insulin. What would you see? So I don't get insulin. I can't eat carbohydrates. My body goes to fat and protein, breaks it down, and now I'm in ketonuria. Now, does that make sense now? Child receives a combination of regular and NPH insulin at 8 a.m. At 8:45, the breakfast trays still haven't come up yet. What do you need to think about? A child got regular and NPH insulin 45 minutes ago. What's your concern? This child's going to go
We
hypoglycemic
gotta
on
get,
you.
yeah, we gotta get them something to eat, right?
Yeah, you need
Yeah.
something now. Give them a glass of milk, orange juice, give them graham crackers, give them something because regular insulin works like this. So you don't want this kid, going out on you. Very good. A child with diabetes is brought into the ER. He's flushed, drowsy, his skin is dry. This child is experiencing what? What do you think is going on here? And this is looking probably that drowsy, dry skin. This looks like DKA. Absolutely. And if you smelt his breath, guess what you would smell? A rotten peach. That's how distinctive it is. You'll never forget it once you smell it. A child with type 1 diabetes mellitus has hyperglycemia, diaphoresis, and headaches in the morning. What condition is this? This one's a harder question on you. And it's emoji phenomenon. Now, don't worry, I don't have these things on the exam for you. It's just one of the conditions where some children get really big high blood sugars in the morning and they don't feel well with it. So these children, they usually say to wake up earlier and treat it with the insulin earlier than to allow them to get to the point with these headaches and that diaphoresis and that horrible feeling. Try to regulate those insulins a lot better with them. What is the function of an insulin pump? I've had 6-year-old little boys teach me how to use their insulin pump, how to give a bolus of 2 units of insulin. It's quite amazing. Give a smart child the ability to control their life, and they're going to want to. It's a continuous infusion of regular insulin, and we put it on children that are alert enough to troubleshoot it, to be able to monitor their blood sugars and give insulin as they need it. Boluses and keeping that diary. It's a great thing. It's one stick in the belly. I had one of my students said she would leave that one needle in her belly for a week. So it's one stick a week, not 3, 4 a day. So it is a lot different. It's better life, actually. Multi. What signs and symptoms will the nurse alert parents of the possibility of ketoacidosis? You're in ketoacidosis. What are you going to feel like? You're not going to feel well. You're nauseous. You feel like crap. You're hungry. You're pale, fruity breath, rotten peach breath. And can you imagine taking a peach, ripe one, put it in a Tupperware, put it in the refrigerator, leave it there for a month or two? Take it out and open that lid, that rotten peach. That's the smell. I had to share that with you. A multi. Why are children are more prone to insulin reactions? I mean, all you need to do is think about children and all of how they're so different, right? Children, they're active, they're not active, they are today, they're not active tomorrow. I mean, they're burning calories at all different things and they're growing. All of these things really make it really hard to give insulin to children. That's why young children need to be involved in their care, know how to take blood sugars, having the schools involved, people who are with them know what to do, how to use the insulin blood thing, and how to give any sort of coverage if they need it. So It's, you know, really involved having a child who's diabetic type 1. What type of precautions are necessary with varicella? How is it spread? That's what that means. It is airborne. It's in the air. You breathe it. That's where it comes from. Which vaccine would be contraindicated for an 8-month-old child allergic to eggs? That's your influenza, believe it or not. Now, is there another one maybe made? You know, it'd be something that would be investigated. They do make different sort of things for like that allergic to eggs if they possibly can. A child's rash was present on the trunk, extremities, face, and the cheeks were bright red. What type of rash is this? This is called the slap face disease. It's a virus. And there's this fine rash all over, but it looks like somebody slapped each face, each cheek. That's the other name of it. It's called fifth disease. That's the other name, that slap face, red face with the rash on. It's called fifth disease. A child is in the prodromal stage of varicella. What does that mean? So that's when they've got it, but they don't get the rash yet. So we don't know yet. And remember, they're contagious now. So they're spreading it, and that's the most dangerous part of varicella. When should the Hep B vaccine be given to infants born to a hepatitis B positive mother? We know that immunization is usually given at birth for all children before they go home, most of the time, all right? But a hepatitis B positive mother, when are we going to give that vaccine? Within 12 hours. That's the key, within 12 hours. This is a child that's not going to do 2 weeks later at the doctor's office. They need it within 12 hours to prevent them from getting hepatitis B. Which classification of medication would make a child most susceptible to an opportunistic infection? As in, which of these make you immunosuppressed? That's exactly what that means. That means opportunistic. It means I can get it. I'm immunosuppressed. It's corticosteroids. Remember, steroids, corticosteroids, steroids. Corticosteroids could be Solumedrol used for asthma, or it could be prednisone orally. It's steroids. And last question, multi. What sources are examples of acquired immunity? So either you get the disease or you get the vaccine, okay? Those are the examples of acquired immunity. Hey, let's see how we did today. Number 3, Marn. Good job, Marn. Number 2, Mila. Good job, Mila. Number 1, Jekka, of course. Number 4, Miss Houston and John. Well, look at everybody here today. That was a really tricky Cahoots. There was some tricky stuff in there. Good job, guys. What I want to do now, we do got a little bit more time left, about 15 minutes. So I'm going to take this time and I'm going to go over some math questions for you. Now, I was told by one of my students, two of them gave her trouble. And because they reached out, Jamila, what was the questions that you had a hard time with? I've got that worksheet set up right now for you.
It's number 4 and not 5, 7. This is my hardest ones.
4 and 7. All right. This is somebody who don't like math, and I've been working with her. Okay. So, hold on, I gotta get it up front. All right. The one thing that annoys me is anybody gets any math questions wrong. There's no reason for it. Not in my book, okay? Because math is not as hard as you all make it, right? So when we think about math in your courses, there's only 3 formulas you need to use. We have a dose to be delivered, dose over what you have available times quantity, right? That's a dose to be delivered, prescribed. You need to deliver, you need to give orders. All of those names are there. Most of these questions are the HQ questions. The other one that you're going to see is mLs per hour. And when you see mLs per hour, you need 2 things in that problem. You need the milligrams to be delivered, the volume, over time in minutes. So you need time and mLs to be delivered. If you don't have time, it's not an mL per hour question. It is a DHQ question. It is a dose. All right, number 4. Great question. All right, let me take out my piece of paper so I can do this along with you. All right, number 4, the doctor orders. Oh, orders, it's a dose. Prescribes, needs to deliver, orders a dose. My dose is 32 milligrams per kilogram per day. And this child weighs 38 pounds. And I need to give that 2 times. Now, they also send me up from the pharmacy. What's available, what you have on hand is 250 milligrams in 2.5 mLs. And then the question says it's per dose. So whatever I get, I want to divide it by 2 and to the 10th. Let's stop. Let's go and let me put up a board that I can do for you. All right. This child weighs 38 pounds. I need to give 32 milligrams per kilogram per day. And it's 2 times in the day. And they sent up a liquid, which was 250 milligrams in 2.5 mLs. All right. The
Professor,
first thing I need to do is what? Yes, ma'am.
Professor, I have a quick question.
Sure.
If we are we still in class right now, or do we
We are
have
still
to
class
leave?
for
Oh,
another 10 minutes. Yes, ma'am.
okay.
We changed those pounds to kilograms.
Okay, and what did you get?
Hold on 1 second. What is that? That is 38 divided
38 divided by 2.2. Now I'm
30.
going to tell you a little hint. You're
It's
going to
like
get a long
17.
number. 17.272727727. And I don't want you to touch that at all. That goes right there. So I need to multiply it by every kilogram gets 32 milligrams. So multiply by 32. 5, 5, 2.7 is the dose, right? Did everybody get that? Jamila?
Yes, I heard you say 38 divided by 2.2 times 32.
38,
38 divided by 2.2
right, times
times
32.
32.
And you get 552.7. So this is your dose for the day to be delivered. I don't do anything yet. And the pharmacy sent me up 250 milligrams, and it was in 2.5 mLs. Now, one of the question is, how do we get to mLs when we're talking milligrams? Well, we have two labels the same over each other. Anything over itself equals 1. So I'm left with mL. So my answer is going to be an mL. So I know that. So if we multiply the top two numbers and then divide, many students like to divide and multiply. Many times you're going to come out with an answer that needs to be rounded before you can do something with it. Don't do it. Leave it there, multiply the top, divide it, and then you'll get your answer. So I have 552.7 times 2.5. I get 1381.81. And I'm going to divide that by 250. And I get 5.527. And this is per day. So I need to divide that by 2. And that's how I get my answer. 2.7. Do you see that, Jamila?
I see what you yeah.
So again, you got to make your dose first. And then you put it in the formula you know. My dose and then what the pharmacy gave me. That's the easiest way to do that equation. All right, the other one that you had a question on was number 7.
Yes.
Okay, great question. And this is the confusion that everybody does. The doctor orders insulin. Oh my God, it's in units. Oh my God, it scares me. But the dose is not a normal number. The dose is 16 units per hour. That is still your dose. And you're going to write that down up top. What did the pharmacy send you?
500.
500 units.
500.
And it's in 500 mLs. All right, let's go put that in a. So your dose, the doctor says it's 16 units per hour. They send up 500 units. And if you notice, I always put this over 1 only to keep it straight. Now, units and units cross off. So it's gone. So I know it's mLs per hour is my answer. So all I do here is multiply 16 by 500 and I divide by 500. And guess what? It's going to be 16. Do you see that now, Jamila?
You said 16 divided by 500.
16 times 500 divide by 500. You multiply the top and then you divide the bottom. And those are basically, your heparin questions. Remember, don't let units bother you because they're going to cross them off anyway. Don't if it's MEQs like potassium, it's a label. You're going to cross that off anyway. It just worked with the numbers that it gave you. Okay. Any other
Okay.
questions regarding that? All
No, I
right,
think I can
guys.
figure it out.
And
Thank
if you
you.
need more help, you let me know. Make an appointment. It's not a problem. I'll meet with you. Anyway, guys, thank you so much. Thanks for sticking and listening to that. I hope it's going to help you in some way. I don't care if it's dose per kilo per minute. It's still a DHQ question. They're not that difficult. Just look at what it's looking for in the end. Take care, guys.
Have a good day.